Let's talk lungs with Trent and Lori from Lung Saskatchewan. Dedicated to connecting you with lung health experts and key opinion leaders who will share current, evidence-based lung health information to inspire you and those you care for to take your best breath. This podcast is recorded on Treaty 6 territory, the ancestral and traditional territory of the Cree, Dene, Blackfoot, Saulteaux, Nakota Sioux, as well as the territory of the Métis.
On this episode, we will be speaking with Dr. Brianne Philipenko, a Saskatoon respirologist and an assistant professor in the Division of Respirology, Critical Care and Sleep Medicine at the University of Saskatchewan.
This episode is sponsored in part by the Saskatchewan Health Research Foundation. SHRF funds, supports, and promotes the impact of health research that matters to Saskatchewan. Find out more at shrf.ca.
Thanks for joining us for today's episode, Dr. Philipenko. Although asthma isn't necessarily new, there are a lot of new treatments becoming more and more available that are changing the lives of those living with asthma, particularly those with severe asthma. We are interested in taking a deeper dive with you today about this on our show.
Let's start by having you tell us a little more about yourself and the specialty that you work in. Why did you choose asthma, and more specifically, severe asthma, as an area of interest?
First of all, thanks for having me. And I would say it was a combination of things that led me to choose asthma as my area of interest. I was doing my respirology fellowship in Calgary and encountered some pretty incredible clinician researchers when I was there in the field of airways disease in particular, including asthma and COPD. They became my mentors and I worked with them on various research projects. I found the science interesting, and so I eventually signed up for an additional year of clinical and research fellowship, specifically in severe asthma. And that year really confirmed to me that asthma was something I wanted to be a large part of my clinical and research practice. And the rest is history.
Thank you for that. I grew up in rural Saskatchewan in a school of 180 kids in the 70s and 80s, and I remember there being only 2 or 3 students that were diagnosed as having asthma. And at that time, they were the kids that always had to sit out certain gym activities, the kids that carried these blue puffers with them everywhere they went. So for those that might not know a lot about asthma, can you give us the Coles notes on what asthma is, and further to that, exactly what constitutes having severe asthma?
For sure. So I usually explain it to my patients as asthma being a condition of the airways. So your main windpipe, your trachea, and then it branches into a bunch of tubes that go throughout your lungs called your airways. Within those airways, you get a combination of things with asthma. You get inflammation and swelling and puffiness of the walls of those tubes, and you get twitchiness. So when that twitchiness happens, the airways narrow off, kind of like a musical instrument, and you hear that wheeze, and patients experience chest tightness. So it's a combination of that, and that's what produces the symptoms. But the underlying problem is really the inflammation of those airway walls. And that's what we treat with our inhalers as well as our new injectable medications. With regards to your second part of your question, severe asthma is asthma that requires our highest dose of anti-inflammatory inhaler therapy. So the way we treat asthma, because it's a condition that involves inflammation and puffiness and swelling of the airways, is we treat it with puffers that decrease inflammation and swelling, anti-inflammatory inhaled steroid puffers. And so those with severe asthma need the highest dose of that medication combined with other components of inhalers that help open up the airways as well. And these are patients that might remain symptomatic even on that high dose, or at least need that high dose to have control of their asthma symptoms. So it's really a retrospective label and depends on what kind of medication a patient ends up needing.
Dr. Philipenko, how commonly is asthma, and for that matter, severe asthma, occurring both globally and in Canada?
Yeah, so it's really quite variable by country, but the estimated global prevalence of asthma is 9.1% of children and 6.6% in adults. I'd say in Canada, we're pretty similar to that as well. But of those with asthma, approximately 3.7% have true severe asthma. And it's a bit of a process to actually make that label, which we can talk about later if you like. But once we review issues with technique, adherence, puffer choice, as well as other conditions that might be triggering asthma, then we can formally say a patient has severe asthma. So it's actually a smaller proportion of that group of patients that have asthma. And that's pretty well close to what we see in Canada. So asthma affects 3.8 million Canadians, and of those with asthma, 250,000 will have severe asthma in Canada approximately.
Can you talk to us a little bit about who's most at risk of developing severe asthma? What would some risk factors be?
That's a big question. And there's likely a combination of what I call modifiable risk factors and non modifiable risk factors. Modifiable risk factors are ones that we can maybe do something about. So, something that might be triggering a patient's asthma symptoms, something that we can change with our actions. And non modifiable risk factors, that would be things like genetic conditions, whether someone has a family history of asthma, what they're exposed to during pregnancy, or shortly after birth. Those things we can't really change much of. And both of these are really a big area of research right now. But probably the most important are the ones that we can impact and change, or the modifiable ones. These would include proper inhaler technique, or on the opposite side, not using their inhalers regularly or correctly. Certain medical conditions like sinus congestion, heartburn, food allergies, pregnancy, anxiety, depression, um, socioeconomic status, so ability to afford their inhalers. Puffers are really expensive and can be hard for many people to afford on a monthly basis. Exposures, so ongoing smoking, e-cigarette use, air pollution, work exposures. There are so many different potential risk factors that can really trigger someone's asthma to become severe. And ultimately, any prior history of a severe flare as well can increase the risk of future severe flares as well.
We are going to take a short break and get right back to our conversation with Dr. Brianne Philipenko.
Lung Saskatchewan has long been associated with leadership in health professional continuing education. Once known as a conference, Inspired Breathing now represents Lung Saskatchewan's renewed commitment to providing continuing education events for healthcare professionals that are responsive, innovative, and centered around partnership. Inspired Breathing inspires innovation, alignment, and partnership in lung health professional education, leading in transforming care. Find out more at lungsask.ca.
Dr. Philipenko, we just finished talking about risk factors for the development of severe asthma. Let's dive a little bit more into how it's actually diagnosed. What would confirm something like severe asthma?
Yeah, so again, it's a bit of a retrospective label and takes a little bit of work to actually get to that diagnosis. But it's someone that requires the highest dose of an inhaled anti-inflammatory, inhaled corticosteroid, is the other word for it, and a long-acting combination puffer that helps open up the airways as well, or as some people refer to it as a 2-in-1 inhaler to keep good asthma control, or perhaps they still are uncontrolled even on that high dose of puffer. To formally diagnose severe asthma, however, like I alluded to earlier, there is a bit of work to be done. So we need to make sure that we have the right diagnosis. So we need to make sure that we've done pulmonary function testing, looked for those findings on pulmonary function testing that really help confirm that indeed the patient has asthma and we're not barking up the wrong tree. We next want to make sure that the patient is using their inhalers properly and that they're using it regularly, not just when they feel sick. And we want to rule out any other medical conditions that might be driving their poor control. So this would be things like uncontrolled sinus congestion, heartburn, those sorts of things, or ongoing exposures. Perhaps a trigger for their asthma is cats, and they have a cat that loves to sleep on their face every night. So addressing all of these potential modifiable ongoing factors first, and then if despite all of that, we go through that entire workup and we don't find anything fixable, that's when we call it severe asthma.
Can you talk to us a little bit about nitric oxide? And for our chemistry gurus, that's FeNO, and why it is a valuable testing tool in severe asthma.
Yeah, so FeNO is a relatively new tool that we have now available in our severe asthma clinic here in Saskatoon, which we're really excited about. A big thing in severe asthma is trying to figure out what type of inflammation and how much inflammation is happening in a patient with asthma's airways. And so we can do that a couple ways. We can do that with lung function testing, we can do that with blood work. But a new test that we have is FeNO, or exhaled nitric oxide. And it's a test where we get a patient to breathe into a handheld device. It's super quick, takes less than 2 minutes. Um, the patient blows out, keeps a cloud on the screen within the middle of the screen for that period of time. And then the device spits out a number of exhaled nitric oxide parts per billion. And that tells us how much inflammation is present in the patient's airways. And it just measures a certain type of inflammation. So it can help guide us in terms of selection of injectable medications, can help guide us in terms of how much inhaled steroid or puffer we should have a patient on. If they have uncontrolled inflammation, we might increase their inhaler, for example. So there's a lot of uses, and we're just starting to explore that in our clinic now in the last couple months, which is really exciting for us.
We are hearing more and more about precision medicine. The world of respiratory care never seems to stand still, and more targeted treatments for those with severe asthma, specifically biologic therapies. Can you talk to us just a little bit about how biologic therapies work?
Yeah, it's really an exploding area in the field of asthma over the last decade. We now have 6 biologic therapies that are available for asthma, which is amazing. And most are injections that function like an EpiPen. One is an IV infusion. Because asthma is an anti inflammatory condition, we have a complex cascade of reactions, chain reactions that ultimately lead to inflammation in the airways that results in asthma. And each of these biologics or injectable medications target a small part of that chain reaction to stop the inflammation that will result in asthma in a more upstream way, if you will. They all work on slightly different targets, which means one might work for one person better than another. And because these medications are targeted, we're also really lucky that our asthma biologics, injectable medications don't seem to impact the immune system or cause much for side effects. They're extremely well tolerated. There's some that are indicated in other conditions as well. So if you have more than one condition, for example, asthma, but you also have sinus congestion with nasal polyps, there's certain biologics that can target both of those conditions. So choosing which one is best for an individual is really nuanced, but is now pushing forward towards that precision medicine model where we're really treating the person that's in front of us with more specific medications.
Yeah, so with a number of different biologic therapies available in the market, how do you, as a respirologist, determine which biologic to try with someone?
It's a combination of what their blood work might show, which would help indicate what type of inflammation they might have, that exhaled nitric oxide measurement that I talked about, and other conditions they might have. So they might have eczema or sinus disease that would help us choose which biologic might work for them. The biologics also have different frequency of injections. So for some people, it's personal preference. But admittedly, it's an area that we need more work and research on because they're all studied in a very similar population, patients with severe asthma with a particular type of inflammation. And sometimes our first pick doesn't end up being the best one, and we end up having to switch. So it's something that we need to get better at. We need to get better at choosing which biologic might be best for the patient up front. But that's certainly something that's ongoing in the world of research.
So, is it ever possible that someone might be on more than one biologic at the same time? Is there any benefit to that?
It is possible. It's very rare. It happens predominantly in people with more than one condition. So, for example, if someone was started on a biologic for their sinuses and we think they need a different biologic for their asthma, Sometimes we can get a patient on 2 biologics, or they might be on a biologic for a totally different condition, like their Crohn's, in which case we can add our asthma biologic in addition to their Crohn's biologic. But it's rare that someone will have 2 asthma-specific biologics at this point in time anyway.
Having said that, is this a lifetime therapy for someone, or do you try it for a year, discontinue, or is this something that if you're on it and it seems to be working really well for that patient, is it determined to be a lifetime therapy?
So currently, it's largely a lifetime therapy because these biologics are newer in the last decade and they work so well. Most patients that we get on the biologics don't want to stop them. It's changed their lives. They want to continue on them indefinitely. And the research hasn't really shown yet at what point might be a good point to try coming off of it or how to do that. For example, it might be a good approach to slowly space out their injections or switch to an injectable that lasts a little bit longer that might be coming down the pipe. But for now, we just continue patients on them indefinitely, and most people, because they've had such a great effect, are happy to do so. And extension studies for all of these injectable medications don't show any long-term side effects that we need to be worried about. So far, we've just been continuing people, but that very well might change.
Thanks, Dr. Philipenko. And for our listeners that might be in the family planning phase of life, can you talk to us a little bit about what we know about asthma biologics in pregnancy? Do we know whether or not they're safe?
Yeah, so that's a great question. It's very hard to study pregnant people. You'll never see a big study comparing a group of people that are pregnant on a medication compared to a placebo, which is how we normally do our studies. It just won't happen because it's very hard ethically to do that type of study. So what we have really for the biologics are what we call case series, or a list of people that have been started on or continued on a biologic during pregnancy. And so far, there doesn't seem to be any adverse outcomes. When I counsel my patients on it, I describe that we have limited evidence for the biologics in pregnancy. The longer the biologic has been around, the more evidence we have, just because more people have opted to continue on the biologic during pregnancy. But ultimately, it's a discussion with the patient because it's essentially the devil you know and the devil you don't. So we know that those with severe asthma during pregnancy might have an increased risk of flares. And if they have poor controlled asthma and they're flaring during their pregnancy, we know that there's a risk to both mom during pregnancy, but also potential growth restriction issues that might happen with the baby, preterm labor. And so far, we have not seen a signal of any adverse effects with these injectables during pregnancy. And I've had several patients that after that discussion have continued on the biologics throughout pregnancy without any issues. So a roundabout way of saying we have some evidence, it's limited, but it's definitely important to maintain asthma control during pregnancy and really try to prevent those flares.
We're hearing the terminology thrown around asthma remission. We hear that term used in cancer, but is asthma remission a possibility with someone with some of the newer therapies?
Yeah. The word remission in asthma is being used a little bit differently than cancer therapy. So I'll start off by clarifying that. So in the asthma world, when we talk about remission, we mean remission on therapy. So someone, for example, that is on a biologic, an injectable medication for their asthma, but now has perfect control of their asthma. They never feel their asthma symptoms. They're not having any flares, and they have good lung function on their pulmonary function test, their breathing test. Essentially, it's a gold standard for how we hope someone will respond to our treatments. It's different than cancer treatment because remission typically refers to somebody who's completed their treatment. Now they can stop and now they don't have asthma anymore. So we're at an in-between phase right now where remission in asthma is while they're still on treatment. And maybe eventually we'll get to the point where we can start weaning people off of them. But for now, it's on therapy.
Earlier on in our show, we did talk about some of the avoidance strategies to try to move towards well-controlled asthma. But what about some of the other non-drug treatments for severe asthma? We know you have a specific interest in exercise and asthma. Can you talk to us a little bit about this?
Absolutely. I'm a big advocate for empowering patients in their disease journey and education on what they can do day to day to improve the way they feel. There's some evidence that aerobic training can improve asthma control, as well as quality of life and their ability to exercise, particularly in patients with severe asthma. What kind of program would best do so has not yet been detailed. So my research project is looking at a exercise program that we've developed with a physiotherapist modeled after pulmonary rehab, which we use in a bunch of other lung conditions, but not so much in severe asthma. And so we've designed an app to deliver an 8-week program to patients able to do it in their home, exercising with whatever equipment they have, lifting soup cans, for example, as weights, and doing that for 8 weeks. And at the end of the 8-week program, we do an exercise test to see if there's been any improvement or not. So it's something that needs more research, and we're trying to do that here at the University of Saskatchewan, which is really exciting. But certainly aerobic training, I encourage all my patients to do on a regular basis.
Dr. Philipenko, your passion for research certainly comes through, and we're very fortunate in Saskatchewan to have you here as a leader in that space. So can you talk to us just a little bit more about where research is going right now for asthma and severe asthma?
Yeah, I think asthma is one of the currently most researched lung conditions, but I am biased. We have new drugs still coming down the pipes all across the spectrum from mild to more severe disease courses of asthma. We have studies trying to characterize different asthma types, and studies like my exercise study looking at non-medication interventions. In Saskatoon, we have several of these ongoing for both mild and more severe asthma. Those with mild asthma being ones that only need your rescue inhaler as needed, and quite infrequently at that, to more severe, which we've talked about a little bit, including new injectable medications that are coming down the pipeline. Can you believe it? Even after having 6, that might benefit patients, particularly those who have a hard time accessing different drugs. So we get first access to that as being a part of these studies. So I would like to put in a plug and say that if anyone's interested in participating in research, regardless of how severe your asthma is, whether it's mild or more severe, feel free to email myself or asthma.lab@usask.ca.
Wonderful. We're enjoying this conversation very much, but unfortunately, we're getting to the end of our time together. But we do have another question for you. We know you don't have a crystal ball, but what do you think the direction research is going, if we might find at some point a cure for asthma?
Possibly, but we're getting close to the next best thing, which is medication that can make someone feel like they don't have asthma with virtually no side effects. That's that remission term that we were talking about, where they can just live their lives like they normally would, other than the odd injection once a month or once every 2 months or maybe even longer that they have to do with the injectable medications. So we're a ways from a formal cure where someone may not have to take anything and not feel like they have asthma, but we're doing pretty well in the research world and getting patients back to living their best lives, at least on treatment for now.
Dr. Philipenko, thank you so much for joining us for this episode. We appreciate you and the important work you are leading in Saskatchewan, which certainly has impact beyond our borders for those suffering from severe asthma. And thank you so much for making time to talk with us today on Let's Talk Lungs.
Thanks for having me.
Thanks for listening. If you enjoyed this episode and you'd like to help support Lung Sask's Let's Talk Lungs podcast, please share it with others. Post about it on social media. Like, subscribe, hit that notification bell for new episodes, and leave us a review. Follow Lung Sask on Instagram @LungSask and on X @LungSask. That's all for this episode. See you next time.
Produced at
Sound Lounge by T-Bone.